The remaining sections of this lecture are going to be about common procedures, mostly done by the provider, that may be done in a labor, and the care that we need to provide involving those. So the first thing we're going to talk about is version. Version is turning the fetus from one presentation to another. The most common type of version is external cephalic version. This needs to be done before labor begins. So it's usually done around 36 to 37 weeks. Sometimes they wait till closer to 37 or 38 because sometimes the provider will try to get the baby turned and then induce labor before the baby flips back. This is done to reduce the need for C-section, because remember that most breech births in the US are by C-section. There is some increased risk to breech birth, and there are fewer practitioners who know how to conduct a breech birth because C-section tends to be lower risk. So the prep for this procedure, they're going to get an ultrasound to verify the position, make sure there's only one, make sure there's enough fluid and there's no anomalies that would make this more dangerous. It's also going to estimate the size of the fetus and if there's actually space to do this. So that ultrasound is going to be done generally on the day. And it may not be a go to X-ray, go to the radiology department, get an ultrasound. This may be done on the unit with a portable ultrasound by the provider. They are going to be put on the fetal heart rate monitor, usually long enough to get a non-stress test done, just to make sure the fetus is in good enough condition to tolerate this procedure. The patient will be consented. They'll have to be informed of all the risk and sign a consent form. And then often they're given a medication to relax the uterus. So that's going to be something that is going to counter any contractions. Sometimes that's going to be something like terbutaline, which is an adrenergic agonist. So we know some of the side effects of that med, right? Okay, so some contraindications. Who should not have this version? So when is external cephalic version contraindicated? If there are any uterine anomalies, so if the uterus has any anatomical abnormalities, if they've had any bleeding in the third trimester, because that could be placental, if there's more than one fetus, if there's not enough amniotic fluid. Oligohydramnios is lack of amniotic fluid. Oligo is not enough, too little. Hydramnios refers to amniotic fluid. So oligohydramnios. If there's any evidence of uteroplacental insufficiency, that's why we want a reactive NST before this is done. So any evidence that the fetus is not, or the placenta is not being perfused adequately. If they see a nuchal cord on ultrasound, they're not going to try this because they don't want to risk making that cord tighter. If they've ever had a previous C-section or any other surgery on the uterus, because that manipulation could cause uterine rupture. Or if it's obvious that the fetal head is too big to fit through the pelvis. During the procedure, the nurse's role is to monitor the patient's vital signs, monitor the fetal heart rate, which we would be doing that intermittently. Usually the provider does some manipulation and then we check the heart rate and we continue doing that. We monitor for bleeding. If they're Rh negative after aversion, they need RhoGAM. Sorry, I skipped to post-procedure. During, monitor fetal heart rate and vital signs and help make that patient as comfortable as possible. And then after, we're monitoring those same things. Monitor vital signs, monitor fetal heart rate, monitor them for contractions, because sometimes this can start some contractions. Monitor for bleeding, and then if they're Rh negative, they get some RhoGAM. An internal version is rarely used. Most of the time, it's used to deliver a second twin that turns transverse after the first twin delivers. So when twins deliver vaginally, the first twin delivers, and that decreases the size of the uterus. That sudden decrease in size can actually cause an abruption for the second twin. So we usually want the second twin to deliver fairly quickly after the first twin. And sometimes the change in pressure will cause the second twin to change position. So they may be both head down, first twin delivers, second twin turns transverse. Most of the time, this is podalic, so it's called internal podalic version. The provider reaches in, they will wear a glove that goes much higher. They reach in, grasp the feet, and deliver the baby. There's risk of injury to the mother and to the fetus in this process, and there's no research about safety. So this is typically done as an emergent intervention. There is a large infection risk, and so if this has been done, usually that mom or that patient is going to get some prophylactic antibiotics. The nurse's role in this process is we're monitoring the fetus, and we want to support the mother and try to do as much as we can to provide pain relief. Okay, the next intervention we're going to talk about is induction of labor.